Thank you. So good evening, all the clinicians. On behalf of INTA's Zenit team, I, Dr. Nishan from Medical Affairs team, take the privilege to welcome all of you to our virtual forum called Endocrine Talk Show. And this is one of our most successful webinar forums, and this is going to be 18th episode. And the today's topic is also very, very important and clinically relevant for each and every diabetic patient, for every specialist who treats T2DM patients. So the topic for today's episode is assessment of glycemic control, choosing between the best and the practical. And for that, as always, we have the privilege to have our moderator and anchor, Professor Shubhankar Chaudhary with us. And along with Dr. Shubhankar Chaudhary, we have a galaxy of four eminent endocrinologists from different parts of the country who will be joining us to discuss about this very, very important topic, which is relevant in day-to-day practice for all the Indian clinicians. So I don't think our audience need any introduction to Professor Shubhankar Chaudhary, but as a customary, I would briefly introduce sir. He is a former head, Department of Endocrinology, IPG MER and SSKM Hospital, Kolkata, immediate past editor-in-chief, Indian Journal of Endocrinology and Metabolism, past president, Endocrine Society of India, member subject expert committee, CDESCO, founder patron, South Asian Federation of Endocrine Society, and has numerous publications to his credit in national and international journals. So with this, it is my honor to once again welcome Professor Shubhankar Chaudhary on virtual podium to take ahead the scientific agenda. Over to you, sir.
Thank you very much. A very good evening to all our participants from across the country. Month after month, you have shown so much interest that despite my requesting INTAS to bring this show to an end, they have said no. And so we continue. And we are blessed, as on other occasions, by a very eminent set of panelists, which include, and again, none of them need any introduction to an audience, not only in India, for many even abroad. But nonetheless, we will just maybe use a one-liner for each of our panelists this evening, and I'm very thankful to all of them for joining in. Dr. Ambrish Mittal, currently Chairman and Head of Endocrinology and Diabetes Division of Max Healthcare, PadMax at New Delhi. He is a Padma Bhushan recipient, PC Roy awardee. He's been president of the Endocrine Society of India, and so on and so forth. Next, we have Dr. C.V. Harinarayan, who was with the SVIMS at Tirupati, but now is Director Institute of Endocrinology, Diabetes, Thyroid and Osteoporosis Disorders at Sakra World Hospitals, Bangalore. And he was ranked as one of the top 10 scientific developments for the year 2006. We have been promised to be joined by Professor R.K. Sahai, who again is Professor in the Department of Endocrinology at Osmania Medical College, Hyderabad, and President Endocrine Society of India. And we are also very fortunate to have Professor P.K. Jabbar, who is Professor and Head Department of Endocrinology at Government Medical College, Trivandrum. He's also Director and CEO of Indian Institute of Diabetes at Trivandrum. So with these few words of introduction, let's go into the subject this evening. We are talking about glycemic control, which is so important we understand in the management of diabetes. We hope to have a 360-degree view of this issue. And as always, I would encourage all our participants to put your questions in the chat box, and we shall try and address all of them. And if your questions are left unanswered, please do understand it's either because we have crossed our time limit significantly, or maybe the question was important but may not have been relevant to this evening's topic of discussion, or we felt that the topic had already been covered by some of the panelists before this. So we know that glucose control is important from different aspects. The best known possibly is in relation to microvascular complications. However, in recent trials of anti-diabetic agents, we see a lot of discussion about kidney protection and less about eye protection or about nerve protection, which were so important components of the UKPDS. So can I ask Dr. Ambrish Vittal to clarify about how important is glucose control for microvascular complications? And are there different thresholds for the different complication prevention?
Well, thank you, Professor Chaudhary. It's a pleasure to be here. We all understand the importance of glycemic control in preventing microvascular complications overall. And interestingly, for those who are relatively young, you would realize that before the UKPDS, even this wasn't really that firmly established as a concept. It was a concept, but not really shown clearly in studies, except the DCCT, which showed it in type 1 diabetes in the early 90s. And then the UKPDS, which showed that tight glycemic control, the criteria there being an A1C of below 7, was 7 or less, was able to reduce the risk of microvascular complications. Now, in fact, at that time, the one of the most important things was retinopathy. It still is, but it's not talked about so much now. One of the important things there is that for every 1% reduction in HbA1c, there's roughly a 25% reduction in microvascular complications. And in this data, they refer to retinopathy in general. Now, so the issue was that, yes, it became clear that for microvascular complications, you need better and better and better glycemic control. Now, how low is too low was a question mark. No one knew. And then, of course, there were the ACCORD and advanced studies, which we are all aware of, which actually put this thing on its head, but not really, because what they did show was that when you tried to achieve very tight glycemic control in patients who had some cardiac risk already, you ended up with greater mortality and greater coronary events and whatever. So, but there again, if you look at the advanced study, which used glycoside, and look at it carefully, even in that, if you look at subgroups, when you lower the HbA1c, and there the target is like 6.4 or something, okay, or less. If you bring the A1c there, although the cardiac and other things we can talk separately, but microvascular complications did go down. There was a 14% reduction in nephropathy and progression of proteinuria. That has subsequently been shown. So simply glycemic control does have an impact on microvascular complications. It is true that in general, the better you control, the lower the microvascular complications. The problem sometimes is why Professor Chaudhary is asking this is about possibly because of retinopathy, which has sometimes been shown to worsen in some situations, including with semaglutide and others. And that is largely linked to very rapid correction of glucose control and of glucose level, and a very rapid attainment of target values. When you do that, sometimes you can worsen retinopathy because of various reasons, including the osmotic changes in the vitreous and other things. So basically, yes, glycemic control is very important for microvascular complications. The lower, the better to some extent, unless you're never should we compromise on hypoglycemia. We certainly don't want to produce hypoglycemia. With newer agents, we don't produce much hypoglycemia. So getting tighter control will help us in reducing microvascular complications.
Right. So we have got a very clear direction from Dr. Mittal that definitely with better glucose control, we are able to prevent or at least significantly reduce the risk of microvascular complications. So that's one reason why we should definitely aim for tight glucose control. But of course, he has also made us aware of the risk of hypoglycemia. So we should always be counseling our patients and also taking care of the medications that we use that possibly have the risk of hypoglycemia. So the other question is infections. The relationship between hyperglycemia and infection, of course, it may not be a clear increased risk of infection. It may be higher chances of more severe infection if you have high glucose control. And the other is standard post-operative. Many patients are diagnosed on routine preoperative checkup with a glucose of 250, 300, whatever. And then the surgeon refers the patient to us. So can I ask Dr. Harinarayan, with your vast experience, what level of glucose will ensure that the patient doesn't have infection? Is there such level? And the other, in relation to post-operative wound infection, what would be a reasonable or safe glucose levels to have?
Thank you, Dr. Shubhankar. I will address this question in two portions. One about the post-operative patient in the critically ill patients and non-critically ill patients. The American Diabetic Association gives a target of 140 to 180 milligrams per deciliter. The Society for Ambulatory Anesthesia gives a value less than 180. And American College of Physicians give a range between 140 to 200. So to put it in a nutshell, a value between 140 to 200 is what you target in a critically ill patient. Of course, in non-critically ill patient also, this gets translated to the same thing. If you have a value with this, majority of the times the infections will not spread and the glycemic control will lead to the good recovery of infection.
Right. And what about, and let's say many a time we find a patient in the post-operative period has had a wound infection, wound dehiscence, and the glucose is, let's say, 220 or thereabouts. So, and we get a referral that it's because of poor glucose control the patient has had this complication. So how do we address that? What do we do?
Well, when you look at that point, the glucose gives you a snapshot of that event. If you want to know whether the blood sugars have been really high in the past 3 months, you have to look at the HbA1c, which gives us a better idea of how bad was the control. So if you're seeing a patient with a 220 sugar, maybe the infection and acute situation could have also raised it. So that is a snapshot of that point. To look in retrospect, you should have gone to the HbA1c.
That's true, but will the HbA1c help us in deciding what treatment to offer at this point of time?
It will not. The sugar at that point only will lead you to the
right. Okay. So another very common condition is for patients going in for cataract surgery. And again, the glucose, a known diabetic or recently diagnosed diabetic. So can I ask Professor Jabbar, where would you give a clearance for a safe cataract surgery? And there are eye surgeons, many of them have a defined level. It should be within 200, I'm fine. So what should be our physician's advice in this regard? And I can add that at least, I don't know what Dr. Ambaresh or Dr. Harinarayan does or you do. I generally try to respect what the eye specialist says, that I want a figure within this. I try to get the patient reach that figure so that at the end of the day, the surgeon also needs to be happy, satisfied that we have got the glucose as per his understanding. But anyway, what would Dr. Jabbar suggest?
Thank you, Shubhankar sir. It's a very nice question. Before I start, so let me express my sincere thanks to Intas Pharma for giving a beautiful platform to be shared with the senior doyens in the field of endocrinology. That question is very specific, minor surgery or a cataract surgery. And of course, in continuation with the Hari sir's comment, see, blood sugar should be in a good range. What is this good range? That's a very important question. Now, for a minor surgery, this need not your cataract surgery alone. There are other types of minor surgery which we encounter in our clinical practice. So, for an elective surgery,
and sir, sorry. So, what is your definition of minor surgery? Any surgery is major for the patient.
no, sir, minor surgery, better you discuss major surgery definition. Major surgery definitions, number one, surgery exceeding more than 2 hours, surgery involving viscera, like abdomen, thoracic cavity, and cranium. All these surgeries or type of surgery coming under the category of major surgery. And minor surgery, that's our topic for today. If the glycosylated hemoglobin is more than 10%, probably you can give a label that was totally uncontrolled, not a suitable candidate for minor elective surgery. And otherwise, you can take the patient for surgery. For clarification, let me give an important message to our delegates who are listening to my discussion, our discussion. Diabetes mellitus as such is not an absolute contraindication for surgery. I still remember when I was in Mumbai with Bhandarkar sir and P.S. Menon madam. See, even if you are getting a case of diabetic ketoacidosis, try to buy little time and try to mobilize the patient and take the patient for surgery. That is a usual protocol in our clinical practice. Whatever minor surgery, otherwise patient is healthy, no cardiac disease, everything's fine, blood sugar less than 1, if you are getting less than 150, I'm very, very happy. Even if I'm getting 160 milligrams per deciliter, otherwise stable patient, and if patient is not taking heavy medicine, which is defined as multiple doses of insulin, multiple oral hypoglycemic agents, I don't have any hesitation to send the patient for surgery if the blood sugar is range between less than 160. That's my comment. Of course, a little modification I may take, but this is the general comment from my side, sir. Subhankar, sir.
Right. Thank you. Yes.
Just adding that in certain areas it matters a lot, major surgery, as we are aware. You're aware, Subhankar, of some of the stuff we did in my earlier assignment with cardiac surgery and all that. So in minor surgeries like cataract, for example, I mean, some surgeons say you don't even have to stop blood thinners because the risk, it's almost totally avascular surgery. So and when we were reviewing this, because there was some discussion with the ophthalmologist in our centers, and when we looked at the NHS guidelines, I think there is very little said. HbA1c of 9 is acceptable, actually. So they don't hold back these. So this is the key message that Dr. Jabbar is giving. I'm just reiterating that it's not necessary to block minor surgeries because of glycemic control. Because of moderate glycemic control is okay. Yeah.
Aspirin is a very important point. So there are physicians think that there is no need of stopping aspirin also because they are touching on avascular structure. There is not much controversy, but still people are very comfortable with stopping aspirin.
I'm just saying that. Yeah, you're right.
Right. Can I stick with Dr. Mittal?
Yes,
and you already raised the ACCORD study. So you clearly said for microvascular complication, better glucose control is better to prevent. What about macrovascular complications? Do we gain? Is there any evidence? Yeah.
So let's start again with the UKPDS, okay, which initially did not show much impact on macrovascular complications. But when you followed up those patients later, you found that those who were in the tight control, intensive control group, as defined by UKPDS, actually had lower of 14% lower incidence of macrovascular events, cardiac events, several years down the line. So there is no doubt that there is importance of good glycemic control for macrovascular also. However, one need not be as obsessive as microvascular. The key point there is to avoid hypoglycemia and use the right agents which are cardiac friendly. That's a separate topic. If you want, I can, I can go into that, but that's important. However, having said that, when we talk of macrovascular complications, we have to look at the steno approach, which we all do, the multimodality approach, which means that if you're trying to protect the heart, it's very, very important, of course, to control glucose, but perhaps even more important, to control the cholesterol slash deliver a statin, administer a statin, and of course, control blood pressure. So you cannot expect to reduce cardiac complications in a very big way just by tight glycemic control. And while Accord and Advance did show increase in coronary events and coronary deaths, with very tight control, I think the control aimed was too tight. Number one, number two, there were more hypoglycemias in that group. Plus, there's a question of which agent to use. So I guess glycemic control is important. We need not aim for very, very tight control, but it's also useless to have almost useless to have glycemic control unless you're delivering your statin and controlling blood pressure at the same time.
I'm sure all the panelists will agree on that. And not too long back, I read maybe study back into the results of the Accord, and which suggested something new, which is HbA1c variability. So that's another area, glycemic variability and HbA1c variability from one visit to the next. So if the HbA1c variability is less, then yes, definitely having a low A1C is better. But if the HbA1c variability is high, then of course it's better from the cardiovascular point of view to have a more relaxed A1C. Right. So we go on to very practical day-to-day issues about fasting and PP glucose. How should be done? What should we advise? Who would take it up? Anyone? Dr. Harinarayan, would you like to take that up?
I would take it up along with the monitoring also. So,
okay, sure.
Advising the fasting, you mean to say methodology you're going to talk? You want me to talk, or the
what we tell the patient? I mean, because my experience is several times of, especially for postprandial, the lab tells you to take 75 grams of glucose and do the postprandial in someone who is known to have diabetes. And then the patient says, I just thought I'll skip the medicine for today and see what happens to my glucose level. So what should be our comprehensive package for the patient?
Fasting sugar is under ideal metabolic conditions, about 8 to 10 hours of fasting. Postprandial, you have to take the medication and then see.
Sorry. What about 12 hours fasting? They have to do a lipid profile also, and the lab will say 12 hours fasting for lipids.
I usually
the patient goes into hypoglycemia by that time.
I usually say 8 to 10 hours is sufficient. That's more than sufficient. Right. Now you see very many reports doing lipid profile offhand. No need for fasting and all. Yeah. So there are so many variable opinions there, so I will not get into it. 8 to 10 hours fasting is ideal. That's good enough to go about it. And postprandial is primarily after taking the ideal diet which has been prescribed. Not that day I will take more food, no tablet, more food and tablet. No. What is prescribed as your ideal breakfast and the treatment what has been given. It is primarily to see whether your drug is working or not. It's going to be you want to upscale or downscale a treatment. And that's the most important thing. And usually, yeah, go ahead.
No, sorry to interrupt. No, the other point has been patients often ask us, so is it from the start of the meal or end of the meal? So again,
suppose if you are going to take a meal for hours to breakfast, then we can't go and explain to them. Ideally, you tend to finish your breakfast by about 10 to 15 minutes, that's all.
Yeah.
And at the end of the breakfast, you take it. And there are some drugs which you definitely give before breakfast or at the first bite of the meal you give. And you try to follow the same procedure so that you can see the efficacy of the drug. That's the most important thing. And when it comes to monitoring the blood glucose, self-monitoring of blood glucose at home is probably the most ideal method in a person who has the knowledge, the skill, and the willingness to do. you get a lot of information. It's primarily to get an information about how bad the hyperglycemia, how frequently you are getting the hypoglycemic attacks, and to monitor the blood sugars, fasting and postprandial also. An ideal chart should be of a 7-point or 8-point meal, fasting before lunch, before dinner, post meal, again at 12 a.m. and 12 midnight and 4 a.m. So you get a good control of the whole thing. And in pregnant situations, the frequency will be different depending upon the situation. And the patient who is admitted in the ward, in a critically ill patient, the monitoring profile will be different.
So maybe the patients in Bangalore maybe are different. I don't know. Very few of my patients would do a 7-point blood glucose.
No, nobody does
test.
it nowadays. But for the sake of discussion and completion, we have to. In situations which are very bad, nowadays the CGMS has come. We try to put up CGMS, which we will be discussing maybe later on. But then before the CGMS came in vogue, there were people who were trying to get it done in very sick patients. We have got it done. Very handful of them, not the whole crowd, definitely not.
And who should be doing the SMBG? Every patient with diabetes? That is, whom do we advise?
In patients whose control is not good, is having repeated hypoglycemic or hyperglycemic attacks, or patients who are very sick or ill, critically ill, and where you feel the glycemic control has to be tightened in a short time. For example, in pregnant women where everyday changes will be very important. Or patients after surgery, recovery, are going in for surgery. When the sugars are not controlled, you want to get a tight control, you can make it frequent.
Right. So most recommendations do not advise SMBG even for people who are just on diet and exercise or just on maybe one oral anti-diabetic agent. So, Dr. Mittal, would you advise SMBG for them as well?
So thank you, Shubhankar. I only raised my hand, and for the same reason. Basically, you know how it depends. It's a lot of it is patient driven also. So there are patients in this zone who are actually doing continuous monitoring also, who are in the zone you're talking about. So that's one extreme. But yes, if we were to advise SMBG, definitely those who are anything beyond metformin, which is the usual first drug. Of course, there is a change in pattern there also, but by and large, the first drug. I do suggest some monitoring, even if it's once a week. And I know that's not the guideline, but guidelines are often determined by the cost. And if the cost is not a consideration and insurance is not paying, it helps to have some grip. It keeps the patient aware of what they're doing. It keeps it from slipping out. The fact that they have to check, once a week or once in 10 days, even if they are on just gliptin, metformin type of combination and they are reasonably, it keeps them alert. So I find that a very useful psychological tool to keep patients in check, although I cannot say that I have any data to show that it really changes outcomes in this group of people. But I do think it gives information that I like. So if you ask me, in our clinic, in our practice, and of course, most of the patients we see are complex anyway. We hardly see metformin type of patients. Everybody is doing this. Everybody. Different extents, one per day, one per week, 1 in 15 days, 7 per day, but everyone is doing this.
I fully agree with Dr. Mittal, and I'll quickly ask Dr. Jabbar. I also tend to advise to most people, even going outside the standard guidelines or recommendations, because that can also be a very important learning tool for the subject. If you're eating out and if you check your sugar after eating out, and if you see that the glucoses are reasonable, then we would be more confident that we can allow that to happen, or otherwise, if the glucose is going too high. So, Dr. Jabbar, what is your practice?
My opinion is certain situations, definitely self-monitoring is very, very useful. One is gestational diabetes. Okay, gestational diabetes mellitus. I want to make it very clear that in my hospital, government hospital, patients are ready to do SMBG for gestational diabetes. Okay, not gestational alone, diabetes in pregnancy. I want to make it sure, and most of our patients in government sector, they are doing SMBG. Another area which I find very useful is perioperative management or preparation for surgery. These two areas, I always insist self-monitor of blood glucose for our patient. That's my view. So, but how many times, and it's a very varying opinion. There is no strong data, solid data, as Ambarish sir was discussing. But it's fine. In practice, it seems to be useful. That's my opinion, sir. Over.
Right. So we stay with you. So you ask the person to start SMBG. Most often the question that I get from my patients is that reliable, sir? I did the test and this was the result, where the lab gave a different result. So how do you deal with this? How do you counsel your patients?
So glucometer story started in the year 1956. See, you can call it as a Clark's data. He is one of the pioneer in the area of this technology, or it's popularly known as father of bioscience. And what I feel is subsequently this was introduced for the monitoring part of type 1 diabetes mellitus. It was very important those times, and subsequently that was creeping into the monitoring profile of type 2 also. But the problem, as you said, people will have a lot of concerns regarding the reliability of this glucometer. What I find nowadays, glucometers are marketed by a few reputed companies, whereby the reliability is very good. But you should know certain issues also with this glucometer. But see, by and large, the areas which are very useful, to document hyper, all those things, that's the most important investigation, simplest investigation or fastest investigation to document or differentiate. And the reliability comes with certain small interfering substance and certain technicality also. Internationally, or usually 10% difference is acceptable in any of the laboratory method. If you are using the standard glucometer, see, you will get little variation. Of course, you are reading, most of the glucometers are reading whole blood sugar. It's not the plasma, but in high-tech machines, you will get the converted plasma glucose also. Interfering substance, including your paracetamol, vitamin C, lot of things uric acid, all these things can interfere with the results also. But I think if you sit with the patient, discuss the issues with the patient, most of the patients will accept, they're ready to take the glucometer or SMBG method. In my era, of course, Barish, you know that we were using the visual comparison method. Of course, those methods are out. The current methodology, I think, is very acceptable, very good, and reliable. And I want to convey the message to public also, or patients also. Over to sir.
Right. So I suppose there would be any other opinion for this. And then when they ask you which glucometer should I buy,
oh, sir,
what do you suggest?
It's a political question, sir. It's very difficult. But we are using, so we have a small one. Of course, the strip is the major issue. See, Roche, they are having, I think it's a 12 rupees or 11 rupees. For me, it's very cheap because we are getting government supply. And we have another one also, which is also very competitive price. And I think so for our rate is only 8 rupees. And all glucometers got its own small limitations also. Only thing sometimes, or at least say monthly or every 2 months, you can cross check with your plasma glucose being performed in laboratory. That's the usual methodology which I am advising to my patient. Over to sir.
Right. So if you advise a comparison with a lab, I at least would always tell them, please do it at the same time, because many times patients
same sample.
The sample, the others, would the venous blood be okay for all the glucometer samples? Not all the glucometers, many of the glucometers.
Sample is not the venous sample. See, simultaneously you can go to this donor, which we are doing. Just to make sure that we are not missing anything.
Right. Okay. So the other major advancement, I mean, that's something that we have been using for the last several years, is now using the HbA1c. And I have been told a little while back that at least 700 delegates have already tuned in. So, but I'm yet to see many questions in the chat box. Let me just check the chat box and see. Okay, so there's a question. I don't have the name who has put this question. So, in newly diagnosed young 30 to 35-year-old type 2 diabetes, A1C 7.5 to 8, what target would you set? Okay. Also, do you generally use combination therapy? That's a different area from day one in such young individuals. Dr. Mittal, so what's your target A1C for newly diagnosed young type 2, 30, 35 years?
So that's the kind of patient, Shubhankar, that we see all the time now. I mean, 30-year-old, newly diagnosed, 7.8 HbA1c, obese, bad lifestyle, family history, maybe. What target would I set? Actually, for such patients, I would set a really low target. I would want them to be 6.5. I wouldn't be happy with 7. And on a different note, if there is obesity and other risk factors which are evident, if you really push hard, these are some of them who can actually be converted. I mean, who can actually go into remission if you really are trying hard. So this is the group where we need to hit hard. Unlike, say, an 80-year-old with 30 years diabetes, where you're quite satisfied with 7.5 or at times even 8. But so this group very clearly hit early, hit hard, and try to bring it to 6.5 or even less.
Right. So any one of you can take it. Dr. Bhattacharya says, do Indians have relatively higher A1C as compared to Americans? So are our A1C targets supposed to be any different? There have been some studies across the country, but is there any definite opinion? Dr. Harinarayan?
We have glycosylic hemoglobin data in different races. I don't remember the reference, but see, practically what I understood from that paper, I read it, I think so quite a few months back, very minimal difference is going to happen. So that may be the reason AD and other professionals for they're giving a blanket statement of 6.5 or 7%. There are differences, there are normative data available. I can provide the this data, but I don't remember the data often, sir.
Right. So come to, yes, Amrish, you wanted to make a point?
I was just saying that it's not convincing that the A1C is different. However, it is true, and I don't know if I should answer that now because that's a question I think that...
No, please,
so
go ahead.
Basically,
there are ethnic differences, but it is not that much to make a perceptible difference to say that we have to follow a different range for a different population. It is not that. There are ethnic differences.
Yes.
So my feeling is that the impact that nutritional deficiency anemias have on HbA1c could be influencing normal sort of HbA1c patterns in a community, given the fact that iron deficiency anemia is still so common in India. And the fact that it is clear that when you have iron deficiency anemia, the lifespan of RBC increases and the HbA1c tends to go up. It's not huge. In some studies, it's quite big, actually, a 1% difference, but typically it's 0.5, 0.8%. So if you have a population that is significantly iron deficient, which definitely some of our population segments would be, you would find a slightly higher HbA1c even in non-diabetic, even in the pre-diabetic zone. So you would find that little sort of difference there. It has been shown that when such patients are given iron, the A1C comes down just with iron. So that point is a little nuance that may be there, but overall, in the criteria, there is no difference between different countries at the moment.
Yeah, I'd like to add a small point. When they standardize and compare different region values, all these variables are taken out. Of course, what you're saying in real life is true, but then when you're trying to compare of ethnic differences of one region to another, all these variables are taken out, and those who have normal hemoglobin, no iron deficiency are taken for comparison. Even there are ethnic differences, but it is not that perceptible to make a change and say, well, we Indians follow different race, Americans follow different one, and Africans follow. No, I think
Right.
you will agree with that.
And
Right.
also, Shubhankar, it's
Yeah.
not just iron deficiency. B12. B12 is such
Yeah.
a big,
Yeah.
such a big issue for us. B12 deficiency, iron deficiency, and D are probably
Similar. Yeah.
So B12 deficiency also
Also,
raises the
yeah.
HbA1c. So those are factors that could significantly influence normal A1C patterns in populations.
And,
Right.
Dr.
So-
Mittal, do you see Dr. Mittal, so much of B12 deficiency? So many medicines are coming with the addition of B12 nowadays. Metformin with B12, calcium with B12. Do you see so much of B12 deficiency in your center?
So in the clinic,
I think
I see
you're very
more of
sure.
high B12s. More of
High
B12s.
B12. You don't see B12 deficiency.
But
They come to you and say, I have a high B12. What should I do?
Yeah,
So the whole
it's a
thing has
question.
changed. So
Yeah.
But
I
yes,
think he's right. He's right in a different sector, and different sector depends upon the population. You see, B12 deficiency does exist. I'm not trying to do, but in a place where Mittal is sitting, you won't see B12 deficiency. Definitely not.
Right. And now another question we have in the chat box. So I think discussion on HbA1c has now opened up the discussion, amongst the delegates. So Dr. Mohit would like your comments on, maybe Dr. Haridaran, if you take it, on using A1C as diagnostic test in our population. I think it partly stems from the previous question, whether we have a different A1C.
See, if you have an A1C of 6.4 and above, then you can definitely pronounce as diabetic. Anything between 5.9 to 6.4, you are called pre-diabetic. Anything less than 5.9, you say it's fine. But using it as a diagnostic tool as a first step and say, well, if you want to diagnose diabetes only with HbA1c, is slightly too much, because so many variables now he has pointed out, like that when a population comes to you, you don't know whether he is B12 deficient or iron deficient or whatever it is. So when you have a value to categorically say 6.4 and above, you say diabetic. 5.9 to 6.4 pre-diabetic. Anything less than 5.9 is zero.
Okay, so we talked about the young. What should be the A1C target? So what would be the A1C target in maybe CKD, in presence of CKD? Dr. Jabbar?
Yes, sir. See the A1C for CKD, right, sir?
Yeah. Would you use A1C as your measure of glucose control in CKD, or would you go by other measures?
I think I'd say you can use, there is no harm in using that, but there are a lot of confronting factors which can produce problems. Number one, see, you will get elevated glycosylated hemoglobin in presence of lot of carbohylated hemoglobin. And anemia is a rule, I would say, and there are other confronting factors also. Because of these confronting factors, glycosylated hemoglobin alone is not an ideal methodology for assessing glycemic status. Even fructosamine and glycated albumin, all these investigations have been tried to validate it in diabetic kidney disease. As far as I know, there is no solid data to recommend all these binded proteins for the assessment of diabetic status. But I feel, in these situations, always we should rely on our blood sugar assessment for laboratory or self-monitoring of blood glucose. You can supplement other clinical assessment also. That's my view. For a CKD, especially for a long-standing and CKD of more than 3, something like that, you should be very careful or interpreting these data. That's my view, sir.
Yeah, but many of the newer A1C assays, they usually are not vitiated by presence of carbomylated hemoglobin. But of course, the other issues, anemia, low RBC lifespan, this, that, so many factors are there, absolutely right. And if we at all look at the A1C value, once again, possibly we are not looking to target a very low value because at that stage, possibly very tight glycemic control, despite what we have said that tight glycemic control helps to prevent microvascular complications, but in significantly advanced CKD, possibly it will not slow down further deterioration anymore. Earlier on, yes, definitely it would prevent, but now no longer. And again, the risks of hypoglycemia are much more, so we should be careful. And of course, also use SMBG much more often. So now, from lab measurement of glucose to SMBG and then to HbA1c. Now, the newest kid on the block, as Dr. Mittal has already mentioned, is CGM. So once again, maybe Dr. Jabbar. Sorry, yeah.
One more question in the chat box.
Yes.
One more question for you on the chat box.
Okay. Dr. Mohit, once more. Studies have shown that young obese patients may also have faulty A1C results, something which is common in practice, and PPG is important evaluation. Any comments from any of the panelists? Young obese patients can have false A1C. I'm not aware.
I'm not aware of age or, I mean, at least certainly not obesity. I'm not aware that there may be some study, but I'm not aware of it.
Right. Dr. Jabbar?
Hold good for vitamin D, not for, may hold good for vitamin D, but not, not for A1C.
Okay, right. Yeah, so we throw up our hands. We are not aware. Maybe we'll try and read up. Right. So
regarding sir's question, CGMS. Okay, you are asking a question to me.
Yes.
CGMS, of course, is a good investigation, but same time there are a lot of overuse of this CGMS is also happening here. See, if the patient is having good glycemic profile with beta cell sparing drugs like DPP for metformin and SGL2, and glycosylated hemoglobin is pretty good control, such a situation there is no need. There are certain specific indications where CGMS is useful. Of course, glycosylated hemoglobin is not under control. The available blood sugar is good. Such a situation, you can look for the faulty areas. Is it which time of the day the blood sugar is going up and down? And if the patient has got a classical brittle diabetes also, you can see. And difficult to control also, CGMS useful. By and large, my experience, since we have CGMS from government side and we are using for this type of indications only, not for all patients. But in future, I may use this CGMS more frequently in other situations also. And I did CGMS for gestational diabetes mellitus also because of totally difficult control of diabetes. It was a negative report, I would say. After delivery, we could document Talipes equinovarus deformity with good glycemic control. Sorry, glycemic profile was good, but glycosylated hemoglobin was very high. So what I want to tell you that you should be very careful interpreting CGMS, and there are definite indications which you should follow scientifically. These are the message from myself, sir.
Dr. Mittal, possibly in your practice, you are the one who might be using or maybe having larger proportion of patients who can afford CGM easily. One thing is, of course, the cost many patients may not afford. From your practice, what do you think are the disadvantages, negative points of CGM? There are so many good points, I do understand.
So, yes, I mean, one fundamental problem that we have with the freestyle and, with the ambulatory glucose monitoring is the fact that if you sleep on the side of the sensor, that's pressed a little bit, you get falsely low values. And one of the biggest challenges is the alarms that patients come with, that my sugar is dropping to 40 at night and I don't feel anything. So the inaccuracy of these machines or relative inaccuracy of these machines at the lower end of the glucose spectrum for me is a big challenge and requires a lot of explanation to the patient, even though we explain it beforehand. Now, sometimes we are also slightly confused whether it's a real hypoglycemia or because if there's a lot of difference for us between, say, 70 and 50. 75 and 50. Now, 50 raises alarm bells, and 75, you say, okay, maybe little adjustment is required. So I think for me, that is one big challenge. The second challenge that we face is that some people who actually require it all the time are not comfortable with it. There are a lot of people who are just not comfortable. They find it. I mean, they just find it too much. The older generation find it too much. Don't want to deal with all this. I don't. And bathing, they go and ask about bathing and all that. So that is one discomfort. But there are also others who find it intrusive or problematic to know their values all the time. I mean, that's human psychology. Techies always come and suggest startups, come and talk to me about this app, that app, we'll get so much data. I said, that's good, but only a small fraction of our patients, my patients, are happy with that data. They want to see that data. So I do think that's also a challenge. Cost, of course, you've already said. Some patients, technical issues, it falls off, or, some patients have a skin which doesn't hold it, very elderly patients. So those are issues. But otherwise, I think a use of continuous monitoring devices or techniques has dramatically increased. I mean, all our type 1s use it. Most of our, even though there is a bit of a control, but most of our GDMs use it. They may not use it continuously. They may use it on and off, 2 weeks and then off 2 weeks, 4 weeks, and again on 2 weeks. But our usage of this technology is very high. And I hope that more and more techniques, advances will happen, more convenient, cost will go down. I see that as the future. I think it's going to be the norm for most patients. So our use of CGM technology, in one word, is very, very high. And I think if we know how to interpret and explain to the patient, it can be a very useful tool.
Right.
Of course,
So
if you're asking that, then we look at time in range, we look at those parameters, 80% time in range. We
will soon learn about how to interpret and what to look at from Dr. Harinarayan soon. But one of the points that I have is something that you also mentioned in passing. Too much of data, even for me as a physician, how much use do I have with all that amount of data, especially if I do not have the means of addressing it minute to minute. If my patient is on a pump, yes, you can address that. But otherwise, does it serve a very useful purpose? Unless what Dr. Jabbar has already mentioned, those who have problems, maybe hypos, especially at night, patients quite often are lazy, cannot wake up for practical reasons to check the glucose at night, then it's a very practical means. So, however, let us now understand from Dr. Harinarayan, what are the parameters that we look at and how do we interpret it? And again, for basic clinician, you do not have hours to pour over everything in a CGM. How to look at the report smartly and make the most out of it.
Looking at is first to get the information history from the patient. How far he has been wearing regularly and keeping the meter and collecting the data. It should be more than 70% of the time of what you are going to assess. The data should be there to say that you can give a meaningful report. And then you have to get the background of the patient, what type of insulin he is using, whether it is multiple doses or a single dose, or is he using basal bolus, or is he using any oral drugs, and the type of food he is taking. Then when you come to the data per se, it is very easy to see that you will have 3 parameters: the time in range, time above range, and the time below range. Put it in a nutshell, we expect more than 80% of the time to be time in range, 75 to 80%. Time below the range must be the least, and time above the range must be less than 10%. Then it means to say that you will have a good value. So then what is the time in range value? Any value between 70 to 80, the recorder shows this is time in range. Value less than 70 or less than 54, it shows time below the range. You have the least amount of time below the range so that the control is good. At the same time, the time above the range, anything more than 250, should also be less than 10%. This is a very quick way of it.
Right. Yeah. Dr. Amrish, yeah.
So
You
one of
wanted
the
to-
challenges which I forgot to mention, and Dr. Hanaran brought it up, so I was reminded of it, was setting the time and range on the reader. So what happens is that for an 80-year-old man, you have a time and range that is preset to some 70 to 120 or some anything nonsense, and therefore that is everything looks high. So it's very, very important for colleagues who are using freestyle technology. You have to set the time and range. It's very easy to do that. It takes 5 seconds to do what is actually required for your patient. So if you want someone to be 100 to 180, you can put it there. I mean, that's all right. If you want a pregnant diabetic to be like 70 to 140, you can put it. So what I'm saying is setting the time and range is very important, because the goal has to be individualized. And then, of course, exactly what Dr. Hanaran said.
Right.
But the guidelines say the time in range up to 180 is permitted.
Yeah.
So any value between 70 to 180, the meter is preset to that actually. So even normally, if you normally look back also before the CGM came, what was the reasonable range? We say 140 to 180 is reasonably permitted, and that's what we learned, and that's what we used to say, and that's what is given in this CGM also.
Right. So we should soon be winding up, nearing our one hour mark. So maybe quick ones about fructosamine assay. Do you ever advise any of you? And then whom would you advise for fructosamine? Yes, Dr. Harinaran.
See, I have advised one in the patients with hemoglobinopathies where your HbA1c is no use. I ask them to get it done. Pregnant woman, if you want to look at the glycemic control for a short period of time where HbA1c, which gives an average of 3 months, fructosamine gives it for about 2 weeks, and the glycosylated albumin gives it for 3 weeks. So these are the conditions. Fructosamine is being done in many of the commercial laboratories now.
Yeah, but my problem with fructosamine, I do advise, especially when the more commonly the SMVG results and the A1Cs do not match. Quite often I try to look at it another way and look at fructosamine. But we still do not have a clear sort of target fructosamine.
Yes.
The lab gives you a normal, maybe up to 300 micromoles per liter or something.
Yeah, I agree.
What should be it? For A1C, we have something in mind, maybe 6.5, 7. But similarly, we don't have such idea. That's the whole problem. And what about the other thing, Dr. Ambrish? Maybe anhydroglucitol. You are at the
yes.
edge of technology, leading edge of technology.
Anhydroglucitol, no, I have never used it. For those, just for information, it's a monosaccharide, which is like D-glucose, and which actually a drop in that reflects short-term glycemic excursions. So if you are concerned about short-term excursions and the patient is not on CGM or not doing blood glucose monitoring by glucose sticks very regularly, you can get an idea of short-term glycemic derangements like postprandial hyperglycemia, where you will find a low level of 1.5 Ag. I'm told it's also available in India and it's not that expensive, but to be honest, I have never used it.
I haven't used either. Dr. Harinaran?
I would like to ask Mithil, it is not very costly in these terms. What are the costs?
But there is no data, sir. There is no data.
It doesn't know. Ambition cost is not very much. So what is the cost in Delhi? I just want to know.
I think it's in the zone of 800 or something, somewhere in that zone. I'm not sure, but it's somewhere in that zone.
It gives control for 3 days, if I'm right. Only 3 days per chain. It's not beyond that.
3 days, a little more, and a sharp sort of drop indicates hyperglycemia. But I have never used it. Never asked for it.
Right. So
I think we don't have the need also. Unless you are doing a research study, you are not going to do the monitoring. When you have a CGM, what additional information the other test is going to give you? It's not going to give you.
Yes, sir.
Right. So can we have a quick maybe advice for our physician colleagues from the senior endocrinologists of the country, maybe starting with Ambrish? What advice for glucose monitoring?
I think it's incredibly important that we encourage all our patients to monitor glucose. There may be some where you may think it's not required, but most of them will benefit by glucose monitoring, self-glucose monitoring. Definitely HbA1c done 3 months typically, but in very mild diabetics or others, you may do it 4 to 6 monthly. By and large, 3 monthly HbA1c has changed the way that we manage diabetes several decades ago. Nowadays, CGM is changing the scene, and therefore greater use of CGM in complex patients on multiple insulin shots, drugs that produce hypoglycemia, post coronary bypass. There are so many groups which are sick and serious and require continuous monitoring. There it is helpful. But I think the technology should be helping us in diagnosing and treating our patients. We should not fall prey to using technology for the sake of technology. Sometimes it is patient driven because these things are available to patients. Direct to patient marketing is there. That's okay. But when it comes from our pen, there should be a logic. We should be able to defend. This is why I asked for this test in this patient. So a spectrum of these three: your self-monitoring of blood glucose, continuous glucose monitoring, HbA1c. By and large, these are the things that I use in my practice for monitoring glucose control.
Dr. Jabbar?
Sir, I fully endorse the statements of Ambarish sir. Clinical, of course, with little limitations. SMPG, CGMS with limitations. Of course, we have some limitations mainly because of the cost factor. And all high-tech technologies are useful, but that should be used very sensibly. That's comment from my side, sir. Over.
Professor Harinarayan.
What I would say is, as whatever has been told by the competition Jabbar is right, but we must translate it to the patients that by bringing a tight control and reducing the HbA1c by 1%, we are able to reduce the macrovascular and microvascular complications. That goes a long way in the control of diabetes. That message should come across to the patient. We should not just tell them, do it, it's going to be only this much. 6.5, 6.5, you keep it. But then you tell them that if you keep it at 6.5, your complications do come down. And that education portion should be conveyed to the patient.
So I think so. We finally conclude with a very important message, especially brought up by Dr. Harinarayan at the end, that patient education is very important. Whatever advice we give, whatever technology we use, and particularly in relation to glucose monitoring, why we are advising this, why these are the targets that we are setting. So with this, I would like to wind up with profuse thanks to our panelists, Dr. Ambarish Mittal, Dr. P.K. Jabbar, Professor Harinarayan. Sorry, I'm sure there must have been some commitments at Professor R.K. Sahai's end whereby he couldn't join, but you all made it a very useful learning experience for all our physicians. And by the last count that I have been provided with, about 900 physicians did join, and I hand it back to the organizers. And profuse thanks to Intas for continuing to take the interest and the effort to spread out this knowledge amongst our physician colleagues across the country.
Thank you, sir.
Thank you, Shankar, for always conducting these sessions
very nicely,
deftly and so precisely and so eloquently. Thank you, Shankar.
So I would like to express my sincere thanks to all the three faculties, Professor Harinarayan, Professor Jabbar, and Dr. Ambarish Mittal. And I would also like to express my heartfelt thanks to our moderator and anchor, Professor Shubhankar Chaudhary, who always has provided some great topics to discuss on this forum, which is always very nicely acknowledged and appreciated by all the faculties as well as all the audience. So today's topic was also one very good topic, which was relevant to all the physicians. And looking at the numbers and the number of questions, I think it was very well received by our audience. So once again, my sincere thanks to all the faculties for your taking out your time and giving us some valuable insights on this very, very important topic. So I would also like to express my thanks to all the viewers who have joined us on the Saturday evening, 900 plus physicians. It is always a great number to have this kind of engagement on the virtual forum. So once again, thanks to all, and we look forward to your continued support as we will like to continue this forum further as well. So we look forward to your support, all the faculties, as well as all the doctors. Once again, thank you all from my end. Good night.
Thank you. Good night.
Thank you, Shubhankar. Thank you, everyone.
Bye.